Thank you very much for joining us today at the TICAD9 thematic event titled Saving Africa from the Threat of AIDS Toward a Future Where AIDS is Curable. So I am Miyata Mitsuru. I'm going to taking chair of the panel discussion as well as today's moderation. Thank you very much for your cooperation. This symposium will share the latest clinical policy and research and development insights on HIV/AIDS and explore the potential of international collaboration to advance clinical trial in Africa. We are honored to have experts from both domestic and international fields who are at the forefront of their respective field. Through their valuable presentation and discussion, we will work together to cohort a path toward the future. The first presentation will be given by Professor Michiko Koga of University Tokyo, titled The Current Status of HIV Infection in Japan, Insights from the Clinic. Professor Katagi kindly previously explained who is Michiko-san, so I skipped the introduction. Please begin the lecture.
Thank you very much for giving me the opportunity to be here. Hello everyone, and thank you for attending this symposium. I'm a doctor specializing in infectious diseases, and I care for people living with HIV. Today, I would like to introduce the current situation of HIV. I have no conflict of interest to disclose. HIV has been a global public health issue for more than 40 years, and more than 40 million people have been infected. Most cases are found in Africa. HIV stands for human immunodeficiency virus. It is mainly spread through sexual contact, injection drug use, and from mother to child. In 1981, doctors in the United States reported that unknown immune diseases was spreading among men who had sex with men, MSM. 2 years later, Dr. Valentinosi and Dr. Montagnier discovered HIV. They received the Nobel Prize in 2008 for this discovery. And this figure shows the disease developed after infection. The vertical axis shows the number of HIV virus in the blood. About 1 month after infection, acute HIV syndrome occurs, when the amount of the virus in the blood rises quickly. During this period, the virus spreads throughout the body, including the lymph node. People may have flu-like symptoms such as fever, swollen lymph node, and sore throat. These symptoms usually go away by themselves. After this, the virus levels decrease and the infection enters a chronic phase. In this phase, the person usually feels healthy and has no symptoms. On average, about 8 years after infection, the balance of the immune system breaks down. The virus increases again, the immune system awakens, and people will become sick with opportunistic infections. The stage is called AIDS. Without treatment, it often leads to death. The immune system can also be measured by the number of CD4 T cells in the blood. When the count falls from the normal level of about 1,500 down to 350, diseases such as shingles or tuberculosis may occur. When the number falls below 200, more serious infection, pneumonia, encephalitis, of fungi, of cancers can develop. At this stage, treatment is very difficult even in Japan. Even if people survive, they may have lasting problems such as paralysis after brain infection. It is also harder to restore immune function, and medical costs are very high. Therefore, it is extremely important to diagnose and treat HIV before it becomes AIDS. HIV reproduced inside certain immune cells. Some of these infections are latent, which means the virus is sleeping inside the cell and not producing new virus. Current treatment called antiretroviral therapy, ART, can stop new virus production, but it cannot remove latent virus. This is why HIV cannot yet be cured. ART has improved greatly. After starting ART, the amount of virus falls quickly down and usually becomes undetectable within a few months. The immune system recovers and patients regain their health. One very important message is U equals U, undetectable equals untransmittable. This means the person with HIV who keeps the virus undetectable by treatment cannot pass HIV to their partners. This concept is also called treatment as prevention. Even though treatment is very effective, there is no complete cure. People with HIV must take medicine for life. Only a few people worldwide have been cured through special bone marrow transplants. Therefore, prevention is also very important. One of the most effective methods is PrEP. Another keyword today. PrEP, pre-exposure prophylaxis, is recommended by the World Health Organization, WHO. In 2015, daily oral once tablet was recommended. In 2021, a female vaginal ring was added. In 2022, a long-acting injection every 8 weeks was approved. In 2025, this year, an injection only twice a year was also recommended. Though it is very expensive, about $20,000 per dose. While PrEP is effective, the cost and political issues make it difficult to use widely in many countries. In 2023, more than 3.5 million people had used PrEP at least once, most of them in Africa. Globally, by the end of 2024, about 40.8 million people were living with HIV, including 1.4 million children. To end the AIDS epidemic, the Joint United Nations Program on HIV/AIDS, UNAIDS, has recently updated its annual report, which I would like to introduce here. New infections and deaths are decreasing, but we have not yet reached the target. The goal is 95-95-95 target. 95% of people with HIV know their status. 95% of them are on treatment. 95% of those on treatment have the virus under control. This is a diagram of the HIV care cascade. In 2024, 87%, 89%, 94%, the world came closer than ever. But Not all regions are on track, especially Eastern Europe, Central Asia, the Middle East, and North Africa. Last month, an International AIDS Society 2025 held in Kigali, Rwanda. The most pressing issue was funding cuts. I believe this will be discussed in the following presentations. Now, I will talk about Japan. In Japan, HIV care is available nationwide, mainly at 49 core hospitals, which treat about 80% of patients. Japan also has treatment guidelines updated every year to standardize care. About 30,000 people are living with HIV in Japan, which is much fewer than in Africa. However, about 1,000 new cases are still reported each year, and around 30% are diagnosed late, already at the 8th stage. Most patients are men who have sex with men MSM. Women and children are very few. And this is a Japanese care cascade. In Japan, only about 85% of people with HIV are diagnosed, which is lower than other countries. Testing is difficult to access, and this delay in diagnosis is a major issue. Once treatment begins, however, access to art is good, and most patients can control the virus. There may be more undiagnosed cases in rural areas than in cities like Tokyo or Osaka, partly due to discrimination and prejudice. Among men who do not have HIV, 53% have heard of PrEP, but only 20% started it. PrEP pills were approved only last year in Japan, but they have expensive, about 4,000 yen, $27 per pill. There is no Japanese national database of people with HIV, so I will refer to our hospital as an example. At our hospital in Tokyo, we have treated about 1,300 patients in total. Japan's history with HIV began with people who received contaminated blood products, especially hemophiliacs. About 1,400 were infected, and half have already died. They suffered severe stigma from an early age. Since the introduction of art in 1997, survival has improved dramatically, now almost equal to the general population. As a result, people with HIV in Japan are aging. The median age is 52 years, and some are over 80. Many live alone. Most patients take just one pill a day, while some use long-acting injections. People with HIV in Japan have more complications from a young age than people without HIV. The most common comorbidities are diabetes, hypertension, and dyslipidemia. According to a report from another HIV core center, the main cause of death now are cancer and mental health problems. Further challenges in Japan include early aging, living alone, and health issues such as cancer, heart and kidney disease, and mental illness. In summary, HIV incidence is declining globally. Treatment as prevention and PrEP are essential. In Japan, 30% are diagnosed with AIDS. It is necessary to eliminate discrimination and prejudice. Understand U equal U, and carry out HIV testing. Life expectancy of people with HIV has improved, yet comorbidities and aging are major challenges. HIV care has improved greatly, but challenges remain. Thank you very much for your attention.
Thank you very much. Thank you very much for Michiko-san. So clearly illustrated the medical aspect of HIV and AIDS in Clinic of Japan. Thank you very much. Scarlett-san, please come up the stage. The next speaker, I would like to introduce Professor Scarlett Cornelissen from Stellenbosch University in South Africa. We delivered a lecture titled Status of HIV/AIDS and its Governance in Africa. Please begin your lecture.
Thank you very much, Mr. Moderator, Mr. Chair. And I would also like to thank Professor Yasutomi for inviting me to be part of this session today. It's an honor to be part of the discussion. So as you can see, I'm based at Stellenbosch University, which is in South Africa. It's in the southern part of South Africa. And Professor Koga, she is a medical scientist, but I am a social scientist. So my perspective that I will be presenting is from a social science perspective. And also I want to say that being a South African, I can also give a perspective on HIV and AIDS in a context where HIV and AIDS is actually a normal condition. So Professor Koga has outlined some of the global figures and statistics and incidence of HIV infection. And Africa, and specifically Southern Africa, is the epicenter, really. It is the hub of where HIV infections are the highest. And just to give you some context, so currently at the moment there are 40.8 million people living with HIV globally. In South Africa, there are 8.15 million people that are living with HIV, which means it's around 1/5, 20% of the total population, the total global population. And also HIV prevalence is very high in South Africa. The national total is around 30%, 13%. And then in the population where, the age population where HIV prevalence is the worst, it is around 18%. So the point that I'm trying to make is that I'm coming from a context where, like I said, HIV/AIDS is normal. It's part of normal life, normal daily life. All of us have some kind of experience of being in contact with people living with HIV or trying to fight HIV. But we also don't really talk about HIV/AIDS in public life in the way that is necessary. We tend to talk not directly of somebody is ill with HIV. We say somebody has the big disease or has the dirty disease. So I hope to share some of that perspective with you today, what the lived reality is of HIV/AIDS on the African continent. So these are the topics that I will be speaking to, and won't be covering all of them in too much detail. So as Professor Koga explained, Africa is the region where HIV infections globally are the highest. Currently at the moment, Africa accounts for around 16% of the global population, but 65% of the global HIV infected population live on the African continent. In the beginning, 40 to 30 years ago, when the HIV epidemic was starting to spread globally, the infection rate was the highest on the African continent, but because of some medical and policy responses, HIV infection rate has started to slow down. But we also have we are recording the highest number of AIDS deaths on the African continent. So it's a complex range of causes and social determinants that are driving the HIV epidemic on the African continent. Although it should be said that there have been clear signs of improvement, positive signs of improvement of combating the HIV epidemic in Africa. That's because of two main reasons. There has been greater access to antiretroviral treatments, which Professor Korga spoke about, and also greater social use of medication antiretroviral treatments, which led to a slowdown in new infections in adults, and also a slowdown in the transmission of HIV from mother to infected mothers to children. And as a consequence, AIDS-related deaths have also been slowing on the continent. So as indicated, Africa has the highest HIV infection and prevalence rates, but it's geographically not uniform. The challenge is geographically not uniform across the entire African continent. Southern Africa, which includes countries like South Africa, Malawi, Lesotho, and so forth, they register higher levels of HIV prevalence and HIV infections. And also it's important to note that we're not talking here about one epidemic or one type of medical problem. Because of the complex nature of the HIV virus, which manifests different subtypes and different strains, which Professor Yasutomi will be talking about, we're really talking about a very complex virus and a very complex disease, which is one of the reasons why it has been so difficult really to tackle the HIV/AIDS epidemic head-on the African continent. I want to talk briefly about the determinants, what's driving the HIV infection levels and rates on the African continent, just in terms of three aspects. The first is social and cultural aspects. The second is politics and policy. What have governments done in response to the HIV/AIDS crisis on the African continent? And then what are the current big problematic drivers for new infections on the continent? So in terms of social and cultural factors, this has been mentioned by Professor Korga in relation to Japan, and some of those are very similar in the African context. It's lack of understanding of the HIV virus and of the disease. Social stigma, people don't talk about HIV if you are infected with HIV, and also because the infection is concentrated in specific groups or communities, sexual workers, men having sex with men, and so forth. There's a lot of social stigma related to that, and cultural factors and religious factors also shape how people are open to talk about the HIV/AIDS epidemic. Education levels and maybe not having being properly educated about health and HIV specifically is also a significant social and cultural barrier. In terms of policy and politics, I want to just highlight what sometimes is known as two opposing cases. In other words, to the question of how have African governments responded to the HIV/AIDS epidemic over the past 40 years. So again, it's not possible to talk of a uniform approach. Different governments have adopted different approaches, but maybe two opposing cases. The one case of Uganda, where the under President Museveni of Uganda, they took early on an open approach to tackling HIV, and where the international community also played a big role, especially the United States at that time, played a big role in funding especially prevention measures in Uganda. So the president of Uganda at that time, he publicly declared a campaign and a war against HIV in Uganda, and he zoned in on one measure of doing this, and that was preaching about prevention. How do you prevent infection? Through changing behavior or through having a different attitude in terms of your sexual behavior and sexuality. So his approach to preach really about abstaining and to be faithful to your partner and to use condoms and so forth. And that had a positive impact on HIV infection rates and prevalence in Uganda. By contrast, another case is South Africa, my country, where our government has been criticized, especially in the past, about not being proactive enough to deal with the HIV challenge. And even to the extent where a former president, President Thabo Mbeki, openly and publicly questioned the epidemiological and medical and scientific knowledge base which made link between HIV and AIDS. So he was a case of AIDS denialism, but that also had implications for how the Ministry of Health in South Africa then adopted policies trying to address the HIV infection crisis. In South Africa specifically, for a long time, the Ministry of Health did not support the rollout of antiretroviral treatments. Happy to say that this situation has changed. There's now a different kind of policy attitude in South Africa. There has been a sustained and concerted antiretroviral treatment rollout for the past decades. And that has had a positive impact in terms of, firstly, reducing new infections, and second, and especially mother-to-child transmission of HIV, and secondly, in prolonging the lives of people living with HIV. So AIDS-related deaths have been on the decline. Still, as I said, we still have we have really worryingly high HIV prevalence and incidence rates. So globally at the moment, and also in the African region, we're seeing a shift in pattern where new infections have been slowing globally in general, but new infections are increased in certain key populations. These are sex workers, especially women sex workers, prisoners and detainees, because there's a lot of sexual violence in prison, and also men who have sex with men. So for example, around 25%, a quarter of new infections of HIV in East and in Southern Africa are within these key population. And in Northwest and Central Africa, where the HIV epidemic or the crisis is not quite as severe as in Southern Africa, these are the types of populations where the real problem and challenge lies. So I am not going to spend too much time on this, but just to note that the HIV crisis is a medical crisis, but it's a social crisis first and foremost. It is about how people behave. It is about people's belief systems. It is about how culture and religious values influence people's behavior, their willingness to accept information about HIV, and their willingness to change their behavior. So one of the things that has been a consistent focus of policy responses has been trying to change, for example, gender expectation roles, where women have been advised to if they are not able to if they are in a position where they have to, for example, sell their bodies, or where the male partners are not faithful to them, where they can at least try to negotiate condom use and so forth. And then the HIV/AIDS crisis has, of course, created additional economic and social burdens on the African continent. So we saw the rise of the phenomenon of AIDS orphans, which has now has been mitigated to some extent. A challenge has been that our most economically productive populations on the continent and in the Southern African region has been the population that has seen the highest HIV infection rate and AIDS death rate. So it has filtered down to the economy of Africa. And of course, there are things such as funding, and which I will just briefly return to towards the conclusion. So what long-term solutions? I think the message is that we have made progress, but we have not made enough progress. And as alluded to, one of the reasons is that the HIV/AIDS crisis is a complex crisis. The HIV virus is a complex virus, and AIDS is a complex disease, which means it has to be addressed on multiple foundations through a kind of a multi-perspective approach. So in the beginning, I think it's useful for the context of this session to say that the approach towards dealing with the HIV crisis has been firstly in terms of prevention through changing behavior, secondly through treatment, through the provision of ARTs, other medications and other prophylactic mechanisms, as Professor Koga explained. Now, treatment as prevention, and I think we're moving towards the next phase, which Professor Yasutomi will be talking about, which is cure, right? And he will elaborate on the possibility of a curative vaccine. So the point I want to also just emphasize here is that we have to recognize that there are multiple and diverse routes of the epidemic on the continent, and we also have to start to talk about that the reason why there is this crisis on the African continent is symptomatic of other bigger structural factors and conditions, such as inequality, such as poverty, and so forth. So we have to start to talk about these things much more openly. This is just an example of a campaign led by the Society for AIDS in Africa, which is a society of African doctors who have been working for a long time trying to combat the HIV/AIDS crisis, where they are trying to break down social stigma. And one way in which they're doing that is with having a storytelling video competition, so reaching out to people really at grassroots level. Lastly, so just to conclude, AIDS remains a global public health threat. The need to act collectively, globally, is as ever important as it was 40 years ago. We're now seeing the risk of donor funding being withdrawn, especially with US, the closure of US aid, and the especially the stopping of PEPFAR, which has meant that people who previously had access to ARTs, antiretroviral treatments, that has now suddenly stopped, and the risk is that can down the line lead to higher AIDS deaths in Africa, and also to new infections. We need to, in other words, a reversal of the good progress that was done. So we need different types of knowledge for that. We need biomedical knowledge, we need sociocultural knowledge, we need indigenous knowledge to address the complex nature of the epidemic. But we also need to strengthen, and that's where funding probably should also be go towards on the African continent. We need to strengthen institutions where data gathering capacity is increased surveillance of infections is improved so that there can be an adequate response to deal with the crisis. Thank you.
Thank you very much. Thank you very much, Scarlett. So, the final lecturer is coming from sponsored institute, Professor Yasutomi Sensei, Director of the Primate Medical Science Research Center at the National Institute of Biomedical Innovation, Health and Nutrition, on the topic of development of new treatment for AIDS. Please begin your lecture.
Thank you, Chairman. So I'm very happy to introduce our vaccine project as a therapy against AIDS virus infection. So the history of humankind started from the African continent, Great Rift Valley, about 200,000 years ago, and our ancestors moved from there to around the world. So people call the African continent Mother Earth. Everybody already understands current situation of AIDS in Japan and Africa because you got a wonderful lecture from great two speakers. So today I'm going to talk about novel therapies without no permanent treatment. I don't have to explain that. Important point is HIV virus targets the CD4 positive cells. CD4 positive T cell people call the helper T cell. It's just like a control tower in airport. So you imagine that control tower airport is broken, we cannot take any flight. So it's a very important disease. And also I don't have to explain like this. The important point is still global public health problem. And also as a result of long research, only one hope is that onset of AIDS can be controlled by medication. But this makes another problem. Another problem means we have no cure. So patient must take medication for lifelong. As a result of long research, and AIDS research has significant progress in biological analysis, pathological study, immunological research, and development of therapeutic agent since 40 years. World-class researchers continue for study of AIDS. However, we have no cure and vaccine yet. And I have to explain the treatment method problem as HIV vaccine, HIV drugs is not completely terminate the viruses. And I already talked, needs lifelong medication. And we have to think about side effects of medication. And economical burden is a very, very big problem. An important point is now sometimes we found drug-resistant viruses. And so it is desirable to control the AIDS virus without requiring lifelong medication. So usually HIV is diagnosed by blood test. And if HIV is detected, treatment begins. And this treatment is continued for lifelong. And this continuing treatment imposes economic burden, side effects, and I already talked the emergence of drug-resistant viruses. And also, I already talked the treatment against AIDS is for lifelong. So some African countries have difficulty receiving medication. And these countries have receiving support from mainly United States, but this kind of support have now been cut off. The threat of this point is the number of AIDS patients in Africa will increase in the future. People are afraid. So we need a single treatment that can provide lifelong benefit. So I'm going to talk about our vaccine study. So development of therapeutic vaccine. This will not for long life medication. This is a construct of HIV. It has been reported that NEF-deleted AIDS virus, NEF gene-deleted AIDS virus becomes attenuated viruses. And this attenuated virus was thought to be a candidate of live attenuated vaccine. However, this live attenuated virus could not prevent the infection of AIDS virus. So we construct a new type of vaccines. NEF gene-deleted AIDS virus having adjuvant molecule anti-AD5B were constructed. What is adjuvant? So adjuvant is a molecule that enhances immune responses and usually included in a regular vaccine. However, live attenuated vaccine like this does not require the adjuvant. So this vaccine is a totally new type of vaccine. And we use this vaccine against the cynomolgus monkey AIDS systems. Monkeys are injected with vaccine virus or control NEF-deleted viruses. So NEF-deleted virus show the persistent infection. It's like according to usual AIDS virus. Surprisingly, vaccine virus could not be detected in cynomolgus macaques. And the production of interferon gamma was much stronger than control virus. This suggesting that cellular function of cellular-mediated immunity was enhanced, and this vaccine virus was eliminated. So, and next, we tried to vaccine effect in this vaccine. Monkeys injected with a highly pathogenic AIDS virus, so already injected with a vaccine virus at 37 weeks after vaccine virus injection. So control viruses, persistently infected, NEF-deleted virus showed a plasma viral load according to usual AIDS virus. However, vaccine virus injected monkeys showed a different result. 6 out of 7 monkeys did not show the plasma viral load. And we analyzed these 6 monkeys. So when the highly virulent AIDS virus was challenged after vaccination with vaccine virus, the virulent AIDS virus was below the detection limit in 6 out of 7 animals. In the CVNI, NEF-deleted vaccinated group, highly virulent AIDS virus was detected in all animals. So we analyzed these 6 monkeys. So examine the provider DNA of the virulent strain SHIV in each lymphoid tissue of 6 animals in which the virulent strain SHIV is not detected in plasma. So these 6 monkeys were analyzed in all lymphoid tissues in bodies. The virulent strain SHIV could not be detected in each lymph node tissue in 4 monkeys. So 4 of 6 monkeys are totally eliminated the pathogenic viruses, and 2 monkeys are controlled under undetection level. So important point is this vaccine, all monkey was once infected with highly pathogenic, but after that eliminated or controlled the virus. So we next further think about the therapeutic vaccine. I already talked. This vaccine eliminates the virus already infected cells. So virus is isolated from HIV positive persons, and NEF-deleted and AD5 incorporated virus should be constructed, and this virus back to original persons. So, if possible, medication discontinuation. So, people infected with HIV need to take anti-HIV drug for a lifetime. But in this vaccine therapy, the adjuvant molecule exerts a strong cell-mediated immunity enhancing effect, and it has possibility to completely control virus from the body and leading to cure. Now you can see the HIV strains around the world. There are many different HIV strains around the world. So roughly speaking, Japan, Europe, and the US as primary strain is subtype B, and Southeast Asia is subtype AE. And in Africa, where the number of patients is the highest is a subtype C. So if we make a vaccine, to complete the control vaccine, we need each types of vaccine. I already talked, Africa is mainly subtype C viruses, so we need to this type of vaccine. But only one point, important point is that HIV is constantly mutating. So we need to the information of latest prevalent virus information. We need it. So we have to make a latest viruses vaccine like this. Next is I can show you our treatment vaccine experiment. So I already talked to you. Our vaccine is already infected viruses eliminated. So we think about after discontinuing, usually people is taking antiretroviral therapy out. So after discontinuing anti-HIV drug administration, inoculated adjuvant molecule expressed attenuated AIDS virus as therapeutic vaccine. So after interruption, antiretroviral therapy interruption has already been reported in some cases. This slide shows that in the human cases, after interruption, all individuals show the viremia and its increase. Similar results are obtained from the non-human primate cases. Next, it's our therapeutic experiment. So we tried to this one as after interruption, we injected with this vaccine virus 1 to 4 times. Now you can see it's a control monkeys. Control monkeys after interruption, plasma viral load gradually increased and developed AIDS and died. And the number of CD4 positive T cells are inversely related to plasma viruses. The number of CD4 positive T cells were gradually increased with treatment, and it rapidly decreased after interruptions. And our vaccine, we injected with 1 to 4 times our vaccines. So plasma viral load did not come up, and the number of CD4 positive cells is normally controlled. So this vaccine showed the therapeutic effects in AIDS viral infected non-human primate after interruption. Therapeutic effect was seen in AIDS virus infected non-human primate without ART. Plasma viral load are maintained undetected level over 6 years now. So 6 years, these monkeys are no therapy, but still healthy. And we established a method to construct the vaccine virus by using the nucleic acid from 2 fragments. In the first time, we succeeded in the vaccine virus for Africa subtype C and for Southeast Asia subtype AE. However, this virus is made by information from database. I already talked, we need the latest prevalent virus information. So we need to continue deeply contact with local researchers in African people. I already talked to you. First of all, HIV is HIV diagnosed by a blood test, and treatment begins, and it's for lifelong. And we have this couple of trouble is this procedure. But if our vaccine became available, it should be first choice is our vaccine. And if it works, we do not need any continued treatment anymore. So we also, will no longer be these 3 points. So we don't have to think about this threat. From these results, we are now considering clinical trials are under consideration in Africa. And venture company has been established to carry them out. And CEO is there. Sam, raise your hand. If you have any question, ask him much better than me. Today I showed you the totally new technique to save Africa from a threat of AIDS. But our technique is not only for AIDS. I think it's very utilized, useful to other disease. So this technique save not only for Africa, but also save our planet. Now, of course, I know I know myself. I'm very big mouse, but I want to share this dream together with all of you. And our project is supported from many folks. Thank you for attention.
Thank you very much, Dr. Yasutomi. Okay, shall we start the panel discussion? So today we have 4 items to be discussed. Okay, the first question is the impact of the AIDS epidemics in Africa on Japan and other countries. First of all, I would like to ask you, Yasutomi-san.
Yes. Yeah. Today I talked about AIDS study, but AIDS is a very, very important point, especially Africa, because, for example, tuberculosis, many tuberculosis patients is HIV positive. And the mother is HIV positive, baby is HIV positive. They cannot take a BCG vaccine or something. So it's a very, very miserable story. It's a bone. At the bone, you are HIV positive, not to take a BCG therapy, and tuberculosis endemic area. So very big impression in the African area.
Thank you. Thank you very much. So from a clinical aspect, I would like to ask you, Michiko Koga-san, the impact of AIDS epidemics in Africa on Japan and other countries.
So I think that, of course, if African, the numbers of AIDS people increase, so the Japanese patient, I think they increase. Because, example, the Mpox is easy to influence the Japanese patient.
Scarlett-san, do you have any comment on it?
Maybe repeat a little bit. Did you ask if I have a comment to the question of the impact of HIV/AIDS in Africa on Japan and the rest of the world? I think that if we think it's only an African problem, then we are never going to solve the HIV/AIDS crisis, and it really is a global health problem.
Thank you. The second question is more long-term effect. For example, 30 years from now, the situation greatly changed. So let's say that as 2024, Africa's population accounts for 18.5% of world's total. But in 30 years, it will account for more than 26%. So 1/4 population living in Africa. So that means the economic impact. Maybe GDP is increasing in that 3 decades. Japan, if we want to keep our country rich and expanding, and for the economic growth, we have to collaborate more with Africa people. Okay? The third question, Scarlett-san, third question, what recent changes are exacerbating the AIDS and the HIV crisis in Africa?
So I think most definitely the biggest is the impact of the closure of USAID and the slash of US funding. It has had an impact on the funding of clinics, which has been providing ARTs to key populations. but also importantly, it has disrupted very important research that has been ongoing on the African continent, research by the United States' National Institute of Health to universities, clinics, and so forth. And I think it should be noted that while globally important clinical research and scientific research is being conducted, that there's also very important research being conducted by scientists on the African continent. I think South Africa is leading globally, but also on the African continent in terms of research. But we're not doing the research for ourselves. We're doing the research for everybody else. And the third risk is that, as Professor Yasutome has said, if we want to advance in terms not only of knowledge but developing therapeutic vaccine, you need the data. You need the latest data on HIV prevalence. That data gets generated or gets captured at clinics. A lot of those clinics are now going to be, and hospitals. A lot of them are under financial strain. The hospitals and clinics, private clinics, are now having to close down. So there will be a disruption in very important data capturing and surveillance systems.
Yasumi-san, could you give me an additional comment on it?
Yes, it's just the number is 80.5% to 26%. It's including the number of people. Number of people is increasing in Africa. It's also so. And the important point is number of people as increase is very important. Is you said it's an economical burden is a very very big problem. So also. Especially your country, South Africa, has a hard system for clinical trial. AIDS and tuberculosis is the highest level, supported by mainly U.S. fund. But now they make a bugs and person, but no budget at all. So it's very very big problem. So we think about other countries, for example, my vaccine or other people's vaccine, except the United States, should be utilized their knowledge, technique, or everything. I want to try to a clinical trial in Japan, but major patient is in Africa. The impact is the biggest in Africa. So of course we already established. I already talked to you. Established a venture company. But if we want to try to, we're a small person in the U.S. or Japan or something. In the company, big target is very very important and impressed. Am I right, Sam? That's right. So we think focus on this situation is not very bad situation, but other things, other persons open for the utilize these all systems. So change our mind.
So, Dr. Koga, I would like to ask you in a clinical aspect. So, on the floor, we talked already. So, you can see the increase of HIV infection on the globally?
Globally?
No. The patient is increasing after the budget cut.
You mean it in Japan? Yes, exactly. Because the patient, if they cannot take the medicine, stop treatment, and the virus load increase again, and they can spread and to transmit many other people. So I think the numbers of patients increase. Yes.
Thank you very much. Scarlett, let me ask you about after the budget cut of USA's, maybe the supply of the art or something like that is diminishing. So what did you see the influence on it?
Yeah, Yeah, so we are about a few months into the budget cuts. So at this stage we're in the phase of panic because we do not fully grasp the nature of the supply, the disruption in supply. So we don't yet have this bigger picture on the African continent. So again, the data and the information, the access to information is quite important. But what we do know is that the most vulnerable populations, so women, people in rural areas where supply of ARTs has been generally also more complicated and more difficult, children, babies that also need some kind of support, and also especially female sex workers and so forth. In other words, key populations that they are directly impacted at this stage.
Thank you. Scholars, can Africa see the other funding sources?
Maybe that's why I'm here. And at TICAD9, so we have to diversify our partners. I don't want to say we need to diversify our sources of funding because I said that it's not only an African problem or an African issue. It's a global challenge. But diversifying our partners, but with any kind of negative change, there are also always opportunities. So yes.
Thank you. So could you ask you, Yasutomi-san, because the President Trump changed everything now, and historically saying we are over rely on U.S. budget. So we can see another budget source like a BRICS. So the other companies now growing.
Oh, yeah, every time I think about the same type of things because, I already talked, they have the all health system and persons and technique or knowledge or something. But if people do not use this kind of facility or something, it's immediately comes down. So I think, you said president of U.S. or something. That's, something fast, America or Japan or something like that. It's leading to by ourselves. So, for example, Japanese person not ignore the Africa or something. It's back to Japan. And now Japan is not a rich country, but so we think about every type of the equal, which is we need it, which person we can help, which area we can save. Every time we calm down, think about that. That's it's that kind of upset guys. We can't ignore that type of guys. So we really calm down and think about we can use it, we can utilize, and we can save, we can help. Think about the next change. I already talked to change our mind. It's not a threat of just one person. At least 3 years. After that, I think it's much better than this one.
Thank you very much. So we are facing very bad situation now, as I said, that President Trump's perturbation of words, and also the European countries is now facing pressure from President Trump to increase the military budget, which leads to squeezing the budget for aiding Africa or something like that. And also the Japan, we are facing the 30 years long economical bad situation. So everything, and also the China economy is now breaking. So that kind of bad situation, but Dr. Yasutomi says that we are hoping that the challenge of the different way of thinking or way of founding, especially today's sessions. You clearly presented curable live vaccine. So shall we talk about the possibility and the applicability to the African people?
So I think, our vaccines are live attenuated vaccines. So it's very difficult to use a preventive vaccine in a developed country because the normal person, usual person cannot. I think it's not easy to inject it with prevalent. But over 30 million person, 40 million person already infected was in Africa. So we can do this. I think, in Africa, it's a very, very real story. It's small number of subtype B or small number of subtype something. But subtype C is a very, very large amount. For example, if effect is just only 10% or something, 10%, 3 million saved a life. It's a very, very, very big impact. And every time people is learning from the experience. So my vaccine is affect 10%, next is 15%, 20% or something like that. And finally, we can save. I already talked. It's a mother continent. So we save Africa means that we save our planet. Am I right?
Yes, I do agree with Professor Yasutomi. I would like to add that, so yes, it is very, very significant. If we're going to advance with something like a therapeutic vaccine, we need to make inroads in terms of clinical trials and so forth. And because of the situation of the virus subtypes on the African continent, I think it's important that these clinical trials are conducted in Africa. So it means you need to have genuine partnerships with the relevant stakeholders, the health authorities, the governments, the practitioners, clinical and medical practitioners, as well as the community. So genuine partnerships are important. Secondly, trust is important, very, very important. So it takes time to build relations of trust, but I think Japan has the advantage that it is trusted globally, and it has a significant trust, a trust dividend in Africa because it has been a supportive partner for Africa's development for many, many decades. However, I think also we need to consider the social and cultural context. So it took a long time for people on the African continent to accept and to take up HIV drug treatment or ARTs. So people will have to be socialized into new types of medication, new types of treatments. So there has to be a mindset change as well.
Thank you very much. And I would like to ask you, Dr. Koga-san. So, such a curative live vaccine. So the Japanese people in what kind of, how much the interest of Japanese people has?
Of course, many patients hope the cure treatment. So, the example, the Professor Yasutomi's clinical trial is very, very excited for Japanese patient also, I think.
Thank you very much. So, maybe so the efficacy and safety of the curative HIV vaccine reported or assured. So everybody on the earth welcome that kind of invention. So let me ask you, Dr. Yasutomi, you established new companies, Vera, Cure Bio. You are following the American greedy process business model to earn much money based on your vaccine.
Yeah, final purpose is to save our planet. I already talked to this. So, why we established a venture company, so maybe you well understand it's very, very difficult to get a funding, get the money, especially HIV is a patient is not so many in Japan. It's very, very difficult. So we have to get a big fund from globally. So I asked the specialist, our CEO, Sam. So next step is we move to your countries and working in your country together with your country's persons. So this means to establish venture companies.
I hope you are doing following the American greedy venture business model.
I'm not sure. Venture model is he knows well.
Some is a combination of Asian and American cultures, and also Japanese culture.
She's a social professor in the social area and very well understand the Japanese. So I already talked to you. You are a key person means that you well understand the Japanese. And he is a venture capital, and I'm a CSO, just science. I think it's a very good combination.
Anyway, Dr. Yasumi, I rely on you. You are seeking for another peaceful business model with your vaccine, okay? So I learned much from Scarlett. Thank you very much. So it is very important to change the social attitude or social structure. So I'm afraid if we have a curative HIV vaccine, then maybe society will be changed. What do you cope with it? Scarlett, could you give me an idea?
Yes, although to be honestly speaking, we can only speculate. We don't have a real understanding of what kind of changes this could bring about. But change is needed, and change is important. So that's why it's important to work with social scientists to research the impact of change and how effective something like a therapeutic vaccine can be.
Can you see African people can change sexual behavior?
I think so, yes. So, like I said, Africa is very diverse, and values are very diverse across the continent, and also because of different religions and religious practices, people have different values about sexual behavior and so forth. And we have seen changes in sexual behavior, so it can be done.
I think the quick change can be seen. The stigma is disappearing. What do you think of it?
It is slowly changing, yes. Yeah, we are now more openly than 30, 40 years ago speaking about the challenges.
The same thing happened in Alzheimer's disease in Japan. The first treatment pill was emerged at the end of 20th centuries. The Japanese families make a secret of that kind of patient, but we openly discuss about the Alzheimer's diseases, and now last year we have second brand new medicine. So that kind of accelerating the curative manners. Okay, we have 5 minutes left. Thank you very much for live discussion. So along with the Yasutomi-san, Scarlett-san, and the Koga-san, the final comment.
Thank you, Miyata-san. So I already talked a couple of times. This is totally new technique, not only for HIV, other viruses, or for example, hepatitis or something, chronic infected viruses are totally same thing. Also, not only for humans, veterinarian vaccine also including, and change your mind, and also, every time we think about, for example, COVID-19 is in front of standing me, but HIV and TB is still very big problem. It's far from us, but it's very big problem in the world is very strong now. So TB, HIV is very neighbors. We have to change mind. HIV, TB, or other disease is a very neighbor disease because we are, for example, now SFTS. Nobody imagines that SFTS is endemic in Japan or something. So infectious disease is every time our neighbors. So change our mind. So next time, if you ask me this technique for other disease or something, tell me. I want to try to do this.
Dr. Yasunomi, thank you very much. But it is TICAD.
Okay. Sorry.
I'm not asking you the possibility of collaboration with Africa.
Yeah, sure. Yeah, no, of course, people understand or not, but Scarlett well know. It's a very relationship in the South Africa and Japan is a very, very good relationship. Over 150 years? Yes, like this. So, and the leading country in Africa. So we can talk and correlation deeply. So to save Africa, I think. So Japan and South Africa is a very, very good relationship. We think contact deeply.
Yes.
Thank you, your turn. Scarlett, and your turn.
So in the spirit of TICAD9, which has the theme of co-create, co-innovate, let us co-create and co-innovate solutions for the HIV challenge in Africa. Thank you.
Yes, I hope we can give cure treatment for all over the world patients. So for near future, so for save our planet. Yes, that's all.
Thank you very much, panelists. Our final conclusion from me, because I talk about AI. So due to rapid changes in global political and economic situation, the AIDS, HIV crisis in Africa is becoming increasingly serious. On the other hand, looking ahead of the next 3 decades, Africa's population and economic growth will provide us with huge opportunity for growth and peace. Africa is not a distant place for us. As with HIV vaccine, which are expected to be effective in treatment, Japan's innovation and efficient support will become increasingly important too. Shall we realize innovation to cure HIV together with Africa? This is my conclusion. Thank you very much. Please give a warm applause to the panelists. Thank you very much. The panel discussion is now concluded. Thank you all for your attention. Thank you very much.